Good evening. Welcome to Rural 50, NMA Live Edition. It's absolutely an honor to be here this evening to discuss this very important and timely topic. As the 126th president of the National Medical Association, an organization rooted in more than 130 years of struggle, service, and sacrifice towards parity and health equity. We stand on the shoulders of thousands of African American physicians who fought for access when access was denied, who demanded justice when justice was delayed, and who delivered care when care was withheld. Our mission is to advance the art of science and medicine for people of African descent through education, advocacy, and health policy, to promote health and wellness, eliminate health disparities, and sustain physician viability. And today, that mission leads us straight into the heart of rural America. Let us tell the truth this evening. Rural America is hurting. Hospitals are closing, providers are disappearing, Medicaid populations are rising, even as resources become scarce. Chronic disease is climbing. Mental health needs are deepening. Mothers are traveling hours just to deliver their babies. And families are choosing between health care and groceries. And entire communities, particularly rural communities of color, are carrying burdens they did not create and should never have to bear. So, the Rural Health Transformation Program, authorized by the One Big Beautiful Bill, or HR 1, is providing a little bit of an opportunity for us to have access to dollars dedicated to improving access to healthcare. Although there are many things that I disagree with in this bill, it is important that we don't get sucked into the trap of not ensuring our interests are met at every single table. So, if we're not careful, we will hear the term rural as a synonym for white, suggesting that Black people have no part of the rural communities. And we know that nothing can be further from the truth. So tonight, we're going to hear from three individuals who will share their expertise on rural healthcare. By the end of this webinar, we will be equipped with the knowledge to get a seat at that table. After we hear from our panelists, I'll start us off with some questions, and then we'll take some questions from you. So get ready. Start developing your questions, put them in the Q&A in the chat, and we will have our team monitoring those questions. So you're going to hear first from Dr. Susan Ward-Jones. Dr. Jones serves as the Chief Executive Officer of a large community health center where she oversees 12 clinical sites, 3 retail pharmacies, and a workforce of nearly 300 staff in the Arkansas area in West Memphis. In addition to her executive leadership role, she continues to practice internal medicine. She's earned a bachelor's of science from Dillard and completed her medicine degree in internal medicine at the University of Arkansas for Medical Sciences. Then you'll hear from Sarah Singleton. She's from Washington, D.C., based here. She's a principal who advises clients across the healthcare sector on federal policy issues, including research, drug development, public health, and the ACA. She previously served as Senior Director of Policy and Advocacy at the Cystic Fibrosis Foundation, overseeing congressional and agency engagement. Before that, she was Deputy Assistant Secretary for Legislation at HHS. She has her MPH from Boston University and her Bachelor's of Arts from the University of Virginia. And lastly, you'll hear from Kathleen Nolan. She's a leading expert in Medicaid reform with deep expertise in the ACA implementation, managed care, payment reform, behavioral health integration, and health information technology. She's built a strong national network across federal and state agencies, foundations, and healthcare organizations. Kathleen previously served as the Health Division Director of the National Governors Association and Director of State Policy for the National Association of Medicaid Directors. She also holds an MPH from George Washington University and a BA, Bachelor's of Arts, from Carleton College. So you can put your virtual hands together and first receive Dr. Susan Ward Jones. Dr. Jones.
Right, I'll start off. Let me share. And can you see my screen?
Yes, you're good to go. Thank you so much.
All right, thank you. Second. Can you still see it?
We can
Can you,
see it. You're good to go.
um, I can't see. No, I can see it. Okay. You can see it now. Okay. Well, thank you so much, Dr. Mitchell. And just want to say that for over 2 decades, I witnessed firsthand how distance, poverty, and lack of resources really shapes the health of our communities. But more importantly, how powerful it is when we bring services directly to the safety net population. Thank you so much to the National Medical Association, for which I'm a proud member, for shining a spotlight on the realities of care in rural America. I look forward to this discussion and showing what we've learned and improving access to care, outcomes, and trust in the communities in which we serve. Just wanted to level set in terms of health centers and where we are across the state of Arkansas. And we are located in the green on the right. Actually, our main site is located 10 minutes from downtown Memphis. And you can still hear me, right?
Yes.
Hello? Okay. And then also wanted to talk about our services. We're community-based, nonprofit established in 1974. We talked about our sites. We serve about 22,000 patients in 2024 and also generating some 75,000 encounters. You can see the number of services that we have, and we're really proud of our transportation efforts. As we know, transportation is often a barrier to receiving care, where we provide free transportation for all of our patients, and you can see the diversity of the staff in which we have. Our patient demographics 2024, you can see our top 3 diagnoses in our health centers: hypertension, diabetes, and obesity, followed by cardiovascular disease. Of course, we see mostly those 18 to 64 years of age, mostly female. You can see our payer mix breakdown and also our race. The preponderance is Black, followed by white at 29%. We serve one of the most medically underserved regions in the country. The needs are significant and the work is demanding, but it is also necessary. Tonight, I want to outline what makes providing care in the Delta uniquely challenging and why our role as a community health center is so critical. When we talk about the Delta, and we really need to put this in context, we talk about, the Delta, and we have to start with the foundational context, which is poverty. Nationally, poverty is around 10 to 11%. In Arkansas as a whole, that rises to 16 to 18%. But in the Delta, we see poverty rates closer to 21 to 22%, essentially double the national rate. This level of persistent, concentrated poverty affects every part of the healthcare experience: access to prevention, ability to pay for medications, transportation, nutrition, and overall disease burden. These economic conditions shape the realities patients live in, and they directly influence health outcomes. Chronic disease is both a cause and a consequence of structural inequities in the Delta. Conditions like diabetes, hypertension, heart disease, and kidney disease are significantly more prevalent and often diagnosed later or managed less consistently. This leads to major differences in life expectancy. In the Arkansas Delta, life expectancy averages 67 to 69 years. The state average is higher, around 72 to 74 years of age, and compared to the U.S. average of 77. The Delta is nearly a full decade behind. These numbers aren't just statistics. They represent lost years of life, earlier disability, and preventable suffering that community health centers are working every day to address. When we talk about structural barriers, we talk about geography and the long distances that patients often have to travel with limited transportation. We talk about poverty and limited resources for health, food, and medications. We also talk about those, broadband gaps and limited digital access. And of course, we really had a spotlight on that during COVID-19. And of course, when patients don't have access, you can't have remote patient monitoring, no patient portal, no online scheduling, and no health education. As healthcare becomes more digital, the digital divide widens existing disparities. Then we talk about workforce shortages with clinicians and dental and behavioral health and specialty care. And of course, we know what that means in terms of access to care. When we talk about clinical barriers, we talk about high chronic disease burden in terms of diabetes, hypertension, chronic kidney disease, and obesity. And oftentimes it's late presentation due to delayed or inconsistent care. Of course, we have fragmented specialty access. And I tell people all the time that health center patients will make you a specialist. They will make you a cardiologist, a nephrologist, because oftentimes it's not available in the communities in which we serve. Then when we talk about social determinants driving medical complexity, we talk about, these are social determinants are poverty, food insecurity, unstable housing, limited transportation, and low health literacy. These are not peripheral issues. They are the drivers of medical complexity. You cannot stabilize diabetes if your patient doesn't have access to fresh food. You cannot control hypertension if they must choose between medication and electricity. You cannot expect adherence when getting to the clinic when it requires a 40-mile trip without a car. Our teams spend as much time addressing these structural barriers as we do adjusting medications. And the success stories that we do have are always those where we've wrapped social support around clinical care. We also have behavioral health and social barriers where we have mental health shortages, long wait times in terms of trying to get folks into mental health coverage. Also, substance use challenges, stigma is still there in terms of seeking help. Food insecurity and unstable housing really kind of add to complexity of care. When we talk about operational challenges for FQHCs, we operate on tight reimbursement margins. We're often operating under what's called continuing resolutions, where it really makes, strategic planning for our organizations difficult. Regulatory requirements are increasing. Recruiting and retaining clinicians is difficult. It often takes 24 to 36 months to recruit a physician. We must maintain quality and access despite financial constraints. We talk about, and we talked about more about the One Big Beautiful Bill, but we're concerned about the Medicaid cuts and what that does for a health center, which is a great payer for any health center. And also there are attacks to our 340B program, which provides low access for low cost medications at a low cost for our patients, but also it provides savings where we can, provide transportation and dental care, which is largely uncompensated. What are we doing? Integrated primary and behavior care, providing telehealth expansion, school and community outreach, mobile services, partnerships with local organizations, and staff pipeline programs that strengthen our impact. Now, why does our work matter? And we're going to just kind of pause there for a minute. In the Arkansas Delta, FQHCs are not alternatives to healthcare. We are the healthcare system. Many of our counties have no private primary care practices, no urgent care centers, in some cases, no hospitals. When people ask, where would these people go if FQHCs don't exist? The answer is very simple. They wouldn't go anywhere. We serve patients regardless of the ability to pay, insurance status, immigration status, literacy, or circumstances. We do this through clinics, mobile units, school-based health centers, community partnerships. In the Delta, healthcare access and equity depend on the resilience of FQHCs. When we talk about the impact on life expectancy, the Arkansas Delta has some of the lowest expectancy statistics in the country, driven by poverty, transportation, food insecurity. FQHCs are working to reverse those trends, one patient at a time. What improves life expectancy here is not a single intervention, it's consistent, accessible primary care. catching hypertension early, preventing diabetic complications. Every time we help a patient reestablish routine care, get their medications, or manage their chronic conditions, we are literally adding years to their life. And in a region where there's a difference in life expectancy based on where you live in this state. When we talk about chronic disease, it's the daily reality of healthcare in the Delta. Our patients aren't just managing one condition, they have hypertension, heart disease, renal disease, obesity, mental health disorders. We are meeting patients where they are, sometimes literally on their front porch. The improvement we see in A1C levels, blood pressure control, and medication adherence is not because we have the fanciest tools, it's because we have built trust. And I would be remiss if I didn't talk about staff contributions. They are the heartbeat of mission-driven healthcare in the Delta. They understand the community because they are from the community. Many of them, including myself, I grew up in Phillips County, one of the poorest counties in the nation. Many of them grow up in the same towns, churches, and neighborhoods as our patients. Our nurses, physicians, community health workers, all of those patients, folks are important. Their work is not transactional, it is relational. And it is that relational care that closes gaps that no algorithm or policy can. Mission driven care, that's what we do in the Arkansas Delta as it relates to FQHC. It's a commitment to serve the underserved even when resources are thin and challenges are heavy. Mission driven care is not dignity, it is justice. It is belief that every person in every corner of the Arkansas Delta deserves the same chance at health and longevity as anyone else in this country. And in closing, the rural Arkansas Delta presents a unique combination of high disease burden, deep poverty, limited workforce, and geographic isolation, making FQHCs indispensable but constantly stretched. Although our work is demanding, it is very meaningful. Despite these challenges, FQHCs continue to serve as the region's primary healthcare anchor, its largest safety net provider, and often its most stable healthcare employer. On a personal note, being an FQHC CEO for the last 19 years has been challenging, but it's been one of the most meaningful journeys. The obstacles faced has sharpened our purpose, strengthened our community, and I am constantly reminded on a daily basis that leadership at the health center is not just a role, it's a calling. Thank you so much.
Thank you, Dr. Ward Jones, for that very compelling um, breakdown of what is happening in rural Arkansas and how important the care that's being delivered there and how you're on the front lines. Next, we have Miss Sarah Singleton. Sarah?
Great. Dr. Mitchell, thanks so much for inviting me to be part of this conversation. And I couldn't agree with you more. Dr. Ward Jones gave us such a great setup for why we're having this discussion about rural health and really sort of making it real. So, in my time tonight, I'm going to give a little bit of a background to you all about the Rural Health Transformation Fund, how we got here, why it exists, and what we know so far about how it will be allocated. So, next slide. So the top line here, I think probably everyone here is an attentive audience and knows that there was a lot of debate through the course of this year that resulted in HR 1 or the One Big Beautiful Bill, which passed on a Republican only vote by actually a very slim majority. So it took until July 4th to do it, and the vote was 51 to 50 in the Senate and 218 to 214 in the House. And I give you those vote numbers because the Rural Health Transformation Program was one of the keys that unlocked the votes to pass this bill. And so that knowing that it was so slim kind of helps you understand where it came from. The reason for the bill was it was the president's major legislative initiative for this year. And the purpose of it was extending individual tax cuts and boosting spending on some of his priority areas, including defense and border security. It really didn't start out as a healthcare bill, but to pay for all of those things that they wanted to spend and the tax cuts, it was partially offset with some pretty significant Medicaid reductions. So today we're going to discuss not much about that, but I do want to give a little bit of context as we get to the Rural Health Transformation Program. So next slide. Um, As you all may be aware, there are some significant impacts of the One Big Beautiful Bill on Medicaid coverage. And that's because of a combination of work and community engagement requirements for Medicaid and more frequent eligibility checks and changes to eligibility requirements. And finally, changes to the way that Medicaid is financed at the state level. So that's a very high level summary of why there are changes. The Kaiser Family Foundation did an analysis specifically just looking at the rural America and estimates about $137 billion reduction in federal Medicaid spending. Overall, by 2034, 16 million people uninsured. That's the official Congressional Budget Office scorekeeping on it. And the National Rural Health Association, after the bill passed, did an analysis and estimates that rural hospitals will lose 21 cents of every dollar in Medicaid funding, and they are disproportionately dependent on Medicaid funding. So I give you all that context, and I particularly pay attention to that first number, that there's a $137 billion reduction in Medicaid spending, because the Rural Health Transformation Program is $50 billion. So you can see it's going to make up some of that loss, but less than half of that loss. Let's go to the next slide. Just very briefly, the projected impacts vary by state. So you can see here, some states in the South are less impacted. That might be a surprise because graphs don't usually go this way, but the reason for that is because many of those states are the ones that have not expanded Medicaid. Therefore, there are fewer people that might lose Medicaid. But as you can see, particularly in the Southwest, those are some of the most impacted states. And of course, within each of these states, there are rural areas. And you've seen that the impacts will be particularly felt there. So there were a number of Republican senators and members of the House expressing concern as the bill was being developed and these projections about the Medicaid losses were coming up. And so, as I mentioned earlier, this creation of the Rural Health Transformation Program was the thing that basically unlocked those last few votes they needed. So people like Senator Hawley from Missouri and Senator Murkowski from Alaska were really ringing the alarm bell and saying, we're really worried. We've already seen all these hospital closures. We're already worried about the disparate impact in rural America, and this is only going to make things worse. So this was the answer that they came up with, and there are still some members that voted against it, but they got just enough votes to make it pass. So let's go to the next slide. So just top line, the Rural Health Transformation Program is a 5-year, $50 billion financial support mechanism aimed at facilitating state-driven efforts to enhance rural health. So the law provides $10 billion for each fiscal year, and this is provided in the legislation. It's not something where Congress has to go back and provide the funding. The bill itself appropriated the funding. And there's a bit of a formula in the law with some discretion. So 50% of the funding is to be allocated equally amongst the states. So everybody gets their little share of it. And then the other half is allocated according to a methodology that the Secretary of Health and Human Services has a lot of discretion over. It accounts for things like the relative share of rural population, the rural facilities. There's a number of different factors. And they did say that at least a quarter of states must be in that pot, but it can be distributed in amounts that are unequal between those states. If we can go to the next slide. So just some basics. So this bill, as I mentioned, passed July 4th, and in the law, it told the secretary, the director of the Center for Medicare and Medicaid Services, that the funding had to be out this year. So it was an incredibly quick timeline. For those of you that have done kind of federal work, usually it's a much longer process for the federal agencies to develop the request for applications and a longer period to apply and a longer period for the agencies to make decisions. And all of that was really compressed here to meet the deadline. So the applications opened September 15th and the deadline to apply was November 5th. And every single state applied, which makes sense because every single state is bearing some of that Medicaid loss in the future. So they all wanted at least the piece that they were entitled to. And states had to develop their application for the funds with a detailed rural health transformation plan for their state. So they have to make certain program integrity certifications and provide other information. And as we'll get to, there's some specific requirements. And so we're now at the point where we're just a few weeks away from CMS making announcements about what each state is funded for. So let's go to the next slide. So the statute requires states to use the funds for three or more health-related activities. And there's a long list in the statute, but just to highlight some of the kind of major buckets of them. First is making payments to healthcare providers. And this was really important to the rural hospitals and other providers that just said, you need to help us backfill and provide funding directly to us. But looking for something a little bit bigger that's a little bit more transformative, they included things like promoting technology-driven solutions, and particularly with this administration's focus on making America healthy, to focus on chronic health and prevention. They talked about workforce and supporting recruitment and retention initiatives, advancing value-based care and innovative payment models. So that's a little bit more sort of structural and systemic. And finally, there's this sort of like catch-all category for additional uses to promote sustainable access to high-quality services. So that's what's in the statute. And if we go to the next slide, the administration did put out some of their strategic goals for the funding, which largely align with what you see in the statute. But given this administration's focus on the MAHA agenda, they talk about making rural America healthy again. They talk about sustainability and access. And then similarly, that workforce development, innovative care, and tech innovation. So I want to go to the last slide of mine, which is, and Kathleen's going to get into this a little bit more. So what do you need to know about what your state's doing? There's a lot of different sources of information, but one particular one that I like is state health and value strategies. If you Google that, you'll find this. And they have that little map that you see on the left there, where you can click on the states, and they, for any state that has made their application public or has posted a summary of it, if you click on it, it's an interactive map. You can find your state's plan. And so that gives you some clues about how to engage, if you haven't already, in what they're putting forward. In my last minute here, there's just one thing that I wanted to follow up on from what Dr. Mitchell said at the beginning. He said that one of the things that people have been sort of saying is that, rural isn't a synonym for white. And I think that that's really important, particularly in this time, this challenging year that we've had, where, the DEI and some similar terms have, really been a target of this administration and sort of no longer politically salient across the board. Where that's the case, and that has maybe stopped or hampered some work, on the other side of it, there really has been this new level of attention to rural America. And there are people who have been talking for years and decades about the disparities and the lack of access and the workforce considerations in rural America. And there's always been some level of support for addressing those. But I think that this issue around the Medicaid cuts in HR1 and the disparate impact in rural areas really brought that to the forefront and made that part of the dialogue. And you really see across the board policymakers responding to that and really wanting to take care of rural America. So I really encourage everyone in this audience to be thinking about that. That is a term that is politically salient right now, and for good reasons that it matters. And so it's a real opportunity to think about the populations you serve or are part of in rural America and make sure that, rural America, just like all of America, is diverse and reflects a range of people and a range of needs. And this is really a way to engage in trying to meet some of those through not just this rural health transformation program, but more broadly, this focus on rural health. So I think I'll leave it there and turn it back to you, Dr. Mitchell.
Outstanding, Sarah, and I appreciate that. I've been in that map and worked that map for quite a while, since we first met a couple months ago in preparation for this webinar. Next, we'll hear from and get your questions ready. I see that there's several that are joining on Facebook Live and here in the Zoom room. Get your questions ready because we want to make sure that we have a robust discussion for the next half of the hour. But before then, we'll hear from Kathleen. Kathleen, take it away.
Terrific. Thank you. And Sarah, thank you for the setup with ending with that map. Um, I am not one for slides. I'm one to talk and look forward to the conversations. And so I'm just going to dive in. Plus, it's harder for me because I'm going to talk about how this is going to play out at the state level, which is quite varied and diverse. So let me start off with that map that Sarah talked about and sort of key off of that. So this is a program where the federal government has put its marker out there and asked states to come to them with their ideas and their thoughts about how this would work in their state. And that is where we are right now. We do expect it is even potential that announcements will be made next week, but as Sarah noted in her slides, announcements of this initial amount of funding, this first year of funding, are expected any moment now. And what happens at that point is where I really want to focus the first part of my remarks, which is each state is going to take their funding and figure out how to put it into effect, put it into work for the state. I want to reflect on something that did come out that I think you all need to be aware of. What the words are in this grant process here say that you have to serve rural populations. And many of you serve rural populations, even if you are not rural based. You might be suburban, you might be exurban, you might have a mix of different facilities, but if you're serving rural populations, that is the requirement. And so a number of states that we have been looking at are defining that not just to be given to only rural providers, but in fact those that may serve rural providers. So this is the first thing I want everyone to look at in their environments when you're reviewing your state's plan is how are they thinking about who is serving the rural community and the rural environment. It may be broader defined than you think it is. So that's one of the things I want people to really look at when you're looking at your at your state's plan. The second thing is how is money going to be distributed? Who is going to be receiving funding? Is it going to the facilities and the providers themselves, the FQHCs, the rural hospitals? Is it going to community groups that will then distribute it differently? Is it going to one-to-one to workforce programs or other kinds of things? So you really want to look and see where the money is being distributed and who is eligible for that. And then each state has put forward a plan. To Sarah's point, they had to submit a plan with detailed ideas, initiatives they want to conduct. The highest number, the state that offered the highest number of initiatives as an idea was in fact Delaware, with 17 different initiatives that they proposed to fund with their efforts. California and Wisconsin on the other end of the scale had 3 initiatives that they were specifically going to focus on. You can see already the scale of each initiative, et cetera, and what it's going to do might vary. We also need to remember that this is going to vary over time. So the first thing that's going to happen is you're going to go look at the plan that your state has and see what it's going to be designed to do. And then there's going to be a funding announcement. So the states may have requested a lot of money and they may only get some of that from the federal government, and they're going to need to sort through and figure out what they're going to do. So this is a very dynamic time for you all to really get to understand what is the state's intention, what is the flow of the money going to look like, what is my level of involvement in that picture in the rural environment. And this is really the time to get activated on it because it's going to be moving very quickly over the next few weeks. There is something else I want to mention too. When Sarah described the funding that will come down, and we've been talking about states are applying, this is not guaranteed. This is going to be a yearly allotment that each state is going to need to be requesting and demonstrating that they're making progress in order to receive the next year of allotment. It is a 5-year program, right? So it may change over time. So get active now, be thinking about and monitoring how the situation is going forward. But I want to speak a little bit more broadly. So that's the first thing, is you got to know what's happening in the rural program. And this is exactly what this webinar is hopefully encouraging you to do. But I want to reflect on one other thing, which is, let's say you're not a rural provider, you're super urban, you are committed to your population. Is this program about you? As was mentioned earlier, there are cuts to the Medicaid program. There are other challenges that you face. And you is a rural health program about you? And I would propose it's about everybody who is serving populations like Dr. Mitchell described in the beginning, those who are not served by others, those who are challenged in receiving support. And the reason I say that is what Dr. Ward Jones emphasized is that poverty is the connective tissue that affects all of her populations. And so I would propose that poverty is also connecting challenged populations in an urban and a rural environment. And that means the solutions will also be important. So if we have rural initiatives that are about improving the workforce in behavioral health, that are about telehealth or quality improvement, if they are about remote patient monitoring or other technologies, I I believe that we have the opportunity to make those statewide initiatives, not just initiatives that are happening in the rural environment. Because if payers are paying for those, if providers are educated on how to use them, I believe that they can spread statewide, even though they might be initiated in this rural program. So I think it is important that even if this isn't directly about you, I think it's about all of us because this is about solutions for populations that are challenged in receiving services and in getting quality health care. So I think everybody needs to be engaged, and I look forward to some discussion of this program and what we can all learn from it. I'll turn it back over to you, Dr. Mitchell.
Thank you. I'll just ask that Sarah and Dr. Ward Jones, if you turn your camera on, we can get into a bit of a discussion in a moment. We do have another guest that I would love to get her thoughts on the rural health transformation program. But before we do that, Sarah, I'm sorry, Dr. Ward Jones, we heard about this funding and how much is coming. Um, and my first question to you is if it could be spent, I know there's a lot of needs, but if you were in charge of how it was spent for the 12 clinics that you run, um, uh, how would you spend it?
I think for me, from the lens that I have and having been doing this for quite a long time, I think our biggest challenge, of course, sometimes is the funding, but more importantly, is the workforce. Is trying to get, providers in a small town like Marble, Arkansas, with a population of, 1,000 at best, that has no amenities, no school system, is trying to get a provider in those areas. So I think it's just trying to provide incentives for those folks, not only for the providers, but for nurses, for behavioral health, also expansion of telehealth in these areas, providing some broadband support. And in that way, we can even, begin to go down the road of more specialty care, more specialty access, even nephrology and those things of that nature. So, and I think also, expansion of GME residency slots and, helping with teaching health centers. I think the more we can get folks in and develop that pipeline of workforce, the better off we'll be for support, but also exposure to the community health center world, and which people are so amazed at what we do with such few resources, but it's much needed in these communities. And we have learned that we have to bring the care to the communities in which we serve.
I have a follow-up question. One of the things that really piqued my interest when you were speaking, you talked about relational versus transactional and ensuring that there is some level of mission-driven work. Can you just expand upon the importance of in rural communities, importance of the physician and the practitioners being from the community that and connected to the community that they serve?
Well, it's people want to be served by someone that's similar to them. And I think for me, being a product of Phillips County and, growing up beside these folks, and I still go to church with them, on a weekly basis. And we've talked about that. I think that makes the difference for me and my ability to connect with the population. I'm the CEO, but I still see patients a couple of days a week, and that keeps me very grounded and relevant. We had a patient that came in, just a few days ago, blood sugar 550, and she stayed there about 4 hours to try to get her blood sugar down and connected her to, Freestyle Libre. It's that relationship, and she was so thankful. So we try to, hire people that are mission minded, that go the extra mile. And obviously, you can't just be there for the money, but what you get, this, appreciation from the patients. You just can't get paid enough some days. So that goes a long way, and that builds trust. And when you build trust, then people come and they get access, and you have improved health outcomes.
Thank you for that. And Kathleen, um, I'm sorry, I'll come to you, Sarah. Sarah, you've been involved in this space, and you have your pulse, your finger on the pulse of kind of the politics of this, of what this is. This notion of discretion, discretion that whether it's and tell me, is it the discretion that's at HHS, or is it the discretion at CMS, or a little bit of both? And what do you think is going to influence that discretion? And to be clear, for the other half of the 50 billion, there's 25 billion we've learned that is kind of formulaic, that's going out to every state equally, and then there's another 25 billion with a B that is at the discretion of CMS, or HHS is what you said, but explain how we can get in front of that discretion.
Yeah, you can think of CMS and HHS as one and the same for this purpose because it's an administration priority and they're going to work together on this. I worked on Capitol Hill for about 8 years, and I know if I were the staffer there, I would definitely be writing a letter for my boss and making calls, and every member is doing that. They're trying to advocate for their state. The reason for the discretion is a couple. One is Congress hates what they call a formula fight when they're taking a pot of money and they're trying to divide it up because there's winners and losers. Members don't like that. So part of it was in the rush to get this done, there was just sort of no way. So they said, we'll sprinkle a little bit to everybody. And, $5 billion a year spread over 50 states, it doesn't add up to very much. So we need this other piece, and we're going to put off the decision. We're going to give it to the secretary. I think, there is certainly going to probably be an element of this that's political, that's trying to reward those whose vote, helped here. But, truly, there's no entity that has more health data than CMS does. And they know a lot, and they've worked with states for a long time and have an understanding of some of the challenges and the particular needs. Plus, there's what's in the application. Are they excited about some of the things? Is there something that's really innovative or something that's really needed? So I think it's a combination of all of those things. And surely there are some states that are going to feel like it's unfair and they didn't get what they wanted, because every state needs this money and they all could probably use it well. But it'll be, I think, a mixture of sort of the politics and the right policy and the data that will drive it. And as Kathleen said, it's any day now. We'll know soon. And I do hope that, the states going through this planning process, which for a lot of them did include a lot of input from their providers and their community. Some of them started before the application was even posted because they knew they had such a short timeline to write it. So I don't want to pretend that there's a magic money tree somewhere that's going to make all this happen without this, but they have put forward a sort of unprecedented level of planning of what they'd like to do. So even if not all of that gets funded right now at the federal level, it might provide a roadmap for some of the transformation they'd like to change through other mechanisms they may have in the future.
Thank you for that. Kathleen, I'm going to come to you. And then I threw my team a curveball and brought in another panelist that I'm going to introduce in just a moment for her comments. But Kathleen, we have several local societies. You heard Dr. Susan Ward Jones is a proud member of the National Medical Association. We have societies all over the country. And these physicians are looking to organize and get a seat at the table. What are your thoughts about how, the best way for our physicians to get a seat at the table for these conversations that are going to have to happen, even though some has happened before the application and to inform the application. But you've taught us, and we heard today that there's going to be more conversation that has to happen in order to spend the dollars.
Absolutely. And I'll be frank, I think Sarah was kind in saying there was a lot of stakeholder engagement in the application process. In many states, when we saw this happen, a few states got ahead of it, tried to do that, but a heck of a lot of them didn't feel they had the time. I think the stakeholder process at the state level is yet to come in many,
Got
many
it.
states. And I think getting activated in that state level conversation is an imperative. I would add that a couple of states, I know I was looking at Florida's application the other day. They are going to create 4 local regional collaboratives that are going to decide how to do this and where to spend the money. Anytime you see that, that to me, Dr. Mitchell, is an opportunity to get a seat at that table. So I think there's this whole chain. You should be thinking about it federally. You should be thinking about it at the state level. And then if there are local coalitions or collaborative efforts in your communities, you want to be a voice at that table as well. So I think it goes all the way from the top to the local area to really have a voice in this.
Well, listen, I'm going to ask to join us briefly, Dr. Lanita White. She joined the CHCA, which is the Community Health Centers of Arkansas, Incorporated, as its chief executive officer in 2022. CHCA is the state's primary care association supporting Arkansas's federally qualified health care centers and community health centers under her purview make up the largest primary care group in the state, caring for over 250,000 Arkansans. And Dr. White previously served at the University of Arkansas, and she also was our local society's president there in Arkansas. And we met not too long ago, just last week, fresh off her honeymoon, where I met with her, and she had so much to say about how much she's read about the RHT, and what her participation even in the Arkansas process. So, Dr. White, I would love for you to give perspective on what you've seen in your review of these state programs, maybe some of the commonalities that you saw, and where you think Arkansas kind of sits amongst those commonalities. If you can give us that in about 3 to 5 minutes, that would be great. And then we got a couple questions from the audience that I want to get to.
Sure, absolutely. Thank you. Well, first of all, I will say thank you for having this conversation. As we saw last week, there are so many of our colleagues who have no idea what's going on with rural health transformation, who have no idea that it's even there or that it exists. And so, if people like us who are reading about it all the time and know about it, it seems like surely everyone should know, but everyone doesn't. The interesting thing, as we looked at the applications, and you are very right, Kathleen, the window of time was short to give comment and to submit any kind of proposal. So you really had to be ready to go when they opened it up. So it was a very short time period. But what I've seen is I've looked at several proposals across the nation. Some commonalities are number one, CMS laid out very clear areas that states had to address. And so those areas were addressed. What we saw a lot of, though, was a lot of workforce, uh, real hard focus on workforce, because I think everyone has been trying to rebuild their workforce after COVID. What we did not see a lot of, and I was proud to see it in the Arkansas proposal actually, was a focus on children. And so this current administration has said in various ways they want to look at things that prevent disease, to prevent disease burden. And honestly, to do that, you have to start with younger people. For us adults, unfortunately, a lot of that disease prevention time frame is over because the disease is there and it's progressed. And so really looking at children and focusing on that a time frame and age group is where I think a lot of where this current administration's focus is going to be. For Arkansas, I think that's going to be one of the things that we focus on is our younger generation and how do we bring them forward in a healthier way and try to prevent some of that disease burden. The other thing that's very interesting about the Rural Health Transformation Program, and you all may have discussed this, is that you cannot put dollars towards infrastructure. So no new buildings, no new facilities. So really figuring out how do we use this money directly for people. So by binding the hands to say no new infrastructure, it really creates an opportunity for us to focus on patients, honestly, and to earnestly do that without setting a 5-year plan to build a new building, right? But the other part of that is now you have to figure out how to do what you need to do with what you have. And oftentimes that's not very easy. So looking at the innovation part, looking at the partnership, we saw a lot of partnership threads throughout all of the proposals that I've looked at. Everyone is figuring out who can I partner with because honestly, nationally, Medicaid is an $800 billion program. 50 billion is a drop in the bucket. So you have got to figure out how to partner with other entities to make these dollars stretch. And so those are some of the common themes that I'm seeing. But honestly, from this administration standpoint, and we really have to focus on where the administration's time and attention has gone and cut through the rhetoric that we hear to figure out what is the common thread that we keep hearing from this administration. And it really is for focusing on children and getting them healthy and moving forward up to basically get a generation that does not have the disease burden that we see in our current times. So quick and dirty, that's what I've seen. That's what I think the focus is going to be on. And where I think definitely Arkansas is going to be focused on, this where I'm going to be pushing our health centers to make sure we're focusing on that, bringing in those practitioners to do the work and make sure that we focus on our children.
Well, thank you, Dr. White, and I appreciate your flexibility and willingness to join us this evening to give us your version of what you're seeing. And you heard it from her: collaboration. You heard workforce. You heard making sure that not just our elders and 50 plus that have disease burden, but our young people have access. A couple questions in the chat. The first one. What is the impact of low health literacy? And on with this bill, how will health literacy play a part? And what is working to address this? Maybe we can go to Dr. Ward Jones first and see what you're doing there in your neck of the woods surrounding low health literacy.
I think the impact of low health literacy is great in health centers, but I think what we try to do is just assume that people, almost don't know and start at that level and make instructions and things, simple and clear, and also training our staff in health literacy and creating that safe space where people are not embarrassed to ask questions and also connecting them with navigators to make sure that they get the resources that they need. And one powerful thing that we've, done recently, and I'm very proud of that, and where we see a lot of health literacy is in when we try to tackle medication adherence. And we recently put a pharmacist on the floor that when we're starting a, new medication, particularly inhalers or insulin, that they will take the time to really talk to them and go into the room. So we are expecting this to really improve our medication adherence efforts, and we know what that means when patients are adhering to their medication. So basically creating this safe environment, language and clear, and having health navigators and just assessing what patients needs, because everyone's need is a little bit different.
Sarah and Kathleen, you heard Dr. Ward Jones kind of give her thoughts on health literacy. Do we think the RHT has room for health literacy related programming as part of the initiatives that could be funded across states?
Yeah, I do think so. I think the chronic condition management place is one of the most key opportunities for health literacy. I think to your point, Dr. White, we do have so many of these issues. And a lot of times part of the health literacy thing is that it challenges that individuals aren't even seeing the specialist, or maybe they only got one specialist appointment in a year and they don't know how to manage their condition. So I think the focus on chronic conditions will be a really key place to promote health literacy. And then I think some of the, to your point, Dr. White, some of the workforce initiatives, to my mind, could also help with that. A number of states propose community health workers or others who are imperatively important for health literacy. This is how we help people manage their health on a day-to-day basis. That a doctor is really important to initiate that conversation, but then you've got to have somebody who can sit with you and help you figure this out. And I think that's really an opportunity for us to utilize the initiatives that are funded here to address those kinds of issues in particular.
Excellent. We have another question with a couple minutes left. Critical access hospitals, safety net hospitals. Sarah, any thoughts about how the RHT, how safety net hospitals? I'll start with you, and really for everyone here, how the safety net hospitals may fit into this collaborative approach to rural healthcare.
Yeah, I mean, critical access hospitals, they are treated specially under the law because of how critical they are and because there is not an alternative. They already have, payment rates that provide them some favorable terms, and they're still also going to suffer here from loss of Medicaid funding. There's the tension that we talked about in this of how much do you just use the Rural Health Transformation Fund to try to plug the holes? The boat is leaking. Do you just try to plug the holes, or do you try to do something different with the boat? Do you try to transform it? This isn't enough money for a huge transformation. So I think that's going to play out differently in different states. And again, to the point of sort of like politics and constituencies and data, some places it really might be the thing that keeps a hospital from closing. And, maybe the funds will be just used to pay for healthcare services to supplement holes. In other places, they may not get as much direct funding, but they may be able to participate in some of the programs that are stemming from this. So as Kathleen said, it's going to sort of vary across the country, but critical access hospitals are certainly very high on the minds, and they have a powerful, for being very small, they have a very powerful voice in Washington because for the people they serve, they are so important and there really isn't another alternative.
And before I go to Kathleen for her remarks, in 20 seconds, Sarah, where do we go from here? And I'm going to go to you, and then I'll go to Kathleen and Dr. Ward Jones, and I'll end with you, Dr. White. Where do we go from here? And the word that I want you to think about is sustainability. That came up last week when we were talking, Dr. White. Sarah, 20 seconds, and then I'll give everybody else 30 seconds to give us where do we go from here in sustainability, and if you want to sprinkle a little critical access hospitals in, then you can. Go ahead, Sarah.
So, we're going to know really soon what states have. So that's going to be what it's going to be. But that does not mean it's the end of the story. Like Kathleen said, it's the beginning of the story. It's time to get engaged and it's time to influence this because you have several years to do that. So it's not too late and get engaged. That's my sort of call to action in my 20 seconds.
Copy that. Kathleen.
Yeah, she stole my notes. Yeah, I think that's really the point is this can't be used to plug holes. If it's used to plug holes, you won't get money in future years. It has to be about some kind of improvement. And I do think that this is an opportunity to really try to do something focused. And that would be my encouragement is to figure out what is the one thing or the two things that will really make a difference and hold on to those throughout this effort. I think that would be really important for us if we're going to try to be successful, is not to get spread too thin, try to do too many things. I think focus will be the difference between being successful and just making some money available.
Copy that. That's great. Dr. Ward Jones.
I think just for me, in terms of for the state of Arkansas, is really trying to right size what's needed for access in these rural areas And of course, this funding needs to be sustainable and innovative, and try to develop more partnerships and relationships. And where there's an FQHC that needs to be, or rural health, or right size the hospital, or consolidation, but stop trying to deliver healthcare as it was 30 years ago. Our state is very different. Industry is left, and we need to right size for access in rural Arkansas. These folks are not going anywhere, so we have to figure out, how to bring the care to them to have the outcomes that we want. So just developing those collaborations and relationships that will drive costs down, enhance the patient experience, and that of the sort. So I think just right sizing what's needed for the state in an innovative fashion.
And Dr. White.
I would say very simply collaboration, consolidation, communication. Figuring out what you do well, what you have that you can offer to others, figuring out what they do well that they can offer to you, how to combine those together and move forward. This is a time to work together as opposed to everyone duplicating services. We cannot afford literally to duplicate services at this time. We've got to figure out how to collaborate and consolidate and, quite frankly, communicate to get patients taken care of.
Well, I want to thank you all for making yourselves available for this very important conversation. And like many said, this is the beginning of the conversation. My name is Dr. Roger Mitchell Jr. I'm the 126th president of the National Medical Association, where our mission is to advance the art of science and medicine for people of African descent through education, advocacy, and health policy to promote health and wellness, eliminate health disparities, and sustain physician viability. National Medical Association was started in 1895 for that reason. And so we stand to be close to you all. If you are not a member of the National Medical Association, you want to learn how to become a member, log on to www.nmanet.org. If you want to get involved in your local communities and get connected to our physicians, find a way where you can get involved both in urban, suburban, ex-urban, I like that word. I heard ex-urban today. And rural communities. You can connect through the website because we want to team up with you. We want to collaborate with you so that we can make people's lives better. I want to thank Jennifer Young and Christina Epperson for their support as staff, our executive director, Mr. Martin Hamlet, and all of the members of the National Medical Association as we continue to fight this fight. Thanks again to Kathleen, Sarah, Dr. Ward Jones, and Dr. White for your participation. And we will be in contact soon. Thanks, everybody, and speak to you soon. Have a great evening.